Hi, everybody. Alex Sandhu. I'm a heart failure cardiologist at UCLA and the Los Angeles VA. I'm really excited to have this opportunity to present on the management of heart failure with preserved ejection fraction. Here are my disclosures. Here are the learning objectives. I'm just going to kind of jump right in and start talking, though. So heart failure is classically stratified based on ejection fraction into those with ejection fractions of less than 40%, which we classically term reduced ejection fraction, those with ejection fractions between 41 to 49% or mildly reduced ejection fraction, and those with EFs or ejection fractions of 50% or higher, which we term preserved ejection fraction or HFpEF. Most of this talk, I'm going to focus on HFpEF, and then kind of at the end, I'll kind of give my thoughts on where that kind of in-between group of 41 to 49% fit in. HFpEF is really important because it represents half, if not more, of all patients with heart failure, and the prevalence of HFpEF continues to increase. HFpEF is a bit challenging to identify and diagnose because we don't necessarily have the really clear objective finding of a reduced left ventricular systolic function, the reduced ejection fraction, to attribute symptoms to it. The presence of heart failure requires the presence of either active heart failure symptoms or prior heart failure symptoms. When we think about heart failure symptoms, and especially in the context of HFpEF, think a lot about shortness of breath from lying flat, shortness of breath from bending over, swelling, and then also some, non-specific symptoms like fatigue. But it's obviously that, there's a lot of different reasons that individuals can have those symptoms. And so that the second part of the heart failure diagnosis really requires attributing those symptoms to abnormal cardiac structure and function. That abnormality can be detected on an echocardiogram. We don't focus on this as much, but there's signs on echocardiogram that suggest abnormal diastolic function, although a lot of people have abnormal diastolic function that don't have HFpEF, making it, further more challenging. Natriuretic peptide elevations can also suggest that there's kind of abnormal cardiac function that explains some of those symptoms. But many individuals with HFpEF have normal natriuretic peptides, or people have elevated natriuretic peptides for other reasons, like kidney failure. So there's often a lot of gray area. I think these multivariable risk scores can also be quite useful for thinking about whether someone has HFpEF and whether we should target HFpEF specific treatments for their symptoms. So to give you an example, this is one of these scores, the H2 HFpEF score, where basically you kind of look at these 5 different characteristics to get their likelihood. So in the case of someone who has hypertension, atrial fibrillation, and 75 years old that has dyspnea, this score estimates that their probability, they would have a score of 4, and so their probability of having HFpEF related to that dyspnea is about 70%. So quite likely, obviously. Mostly going to focus on HFpEF therapy. There's been a huge transformation of HFpEF therapy. If we gave this talk in 2020, I'd have to say that there's no medication therapy specifically approved with clinical trial evidence for improving heart failure with preserved ejection fraction outcomes. Now, just 6 years later, we have 3 to 4 therapy classes that are demonstrated to improve outcomes in patients with HFpEF. I'm going to spend the next few slides on specific pharmacologic therapies, but do want to emphasize kind of these general principles first, which I think are as, if not more important for HFpEF treatment. First is the need to treat congestion or volume overload. The volume overload in patients with HFpEF not only drives a lot of their symptoms, but it also leads to progressive heart and kidney disease. So it's really important to try to minimize the volume overload and edema. And I think ideally, starting with the therapies we're going to talk about that we think are good for HFpEF that also lead to diuresis, as SGLT2 inhibitors and MRAs, but also using loop diuretics as needed. I think second is trying to treat the conditions that contribute to and worsen HFpEF. So that's all about blood pressure control, trying to treat obesity, diabetes, preventing worsening coronary disease. And then we'll kind of get back to this later, but thinking a little bit about mimics of HFpEF that need their own specific treatment. Third is, thinking about comorbidities that might not necessarily be the driver of HFpEF, but really have major impacts on the quality of life for patients with HFpEF. Things like anemia, frailty, and deconditioning, sleep apnea, and thinking about how those treatments can potentially improve quality of life for patients with HFpEF. And then finally, before I kind of get at specific therapies we know improve HFpEF outcomes, I want to speak a little bit about how I generally think about outcomes and treatment benefit in HFpEF in comparison to patients with reduced ejection fraction, which I know several of the kind of prior Project Echo series have kind of focused on. Um, Among patients hospitalized for heart failure, you'll often hear, and it's true, that outcomes are just as bad for patients with HFpEF as they are for patients with heart failure with reduced ejection fraction. But I think there's two big caveats to that point. First, patients with HFrEF have more of their hospitalizations and death directly related to their heart failure. So treatment with heart failure specific drugs will lead to larger absolute benefit, even if the drugs have similar kind of relative efficacy in the two groups. And then I think second, as Connie already mentioned, I think the diagnosis of HFrEF is quite straightforward and quite objective, whereas actually classifying patients that have HFpEF can be more challenging. Many patients with end-stage renal disease are often misclassified as HFpEF, for example, when it's really not the cardiac abnormalities in those individuals driving their morbidity. So I think that's important when we kind of contextualize the kind of magnitude and level of benefit for some of our therapies. So with therapies, I'm going to start with SGLT2 inhibitors, which I think also have been discussed in prior sessions. This is just a kind of brief overview of a meta-analysis of the 5 largest trials of SGLT2 inhibitors and how they end up impacting major clinical outcomes. When you look at the bottom left, cardiovascular deaths, SGLT2 inhibitors led to a 12% reduction in cardiac, let's see if I can get the laser pointer, a 12% reduction in cardiac death in the HFpEF population, which is very similar to the 14% reduction in the HFrEF population. When you look at the top right here, at heart failure hospitalizations, SGLT2 inhibitors led to a 26% reduction in heart failure hospitalizations in the HFpEF population, very similar to the 31% in the HFrEF population. But when we look at all-cause death, we do see differences between HFrEF patients and HFpEF patients. And we see a significant benefit in all-cause death in HFrEF and the absence of that in patients with HFpEF. And part of that might be that in HFrEF, about 75% of the deaths are cardiovascular, but when we look at HFpEF, less than 50% of the deaths are cardiovascular. So I think, this is all, I think, rings true for everybody on this call that individuals with HFpEF have a lot more multimorbidity that contribute to their morbidity than the cardiac disease by itself. And I think it's important to recognize that. SGLT2 inhibitors have been found to also lead to a small improvement in patient-reported quality of life. So I think, in summary, SGLT2 inhibitors clearly improve outcomes in patients with HFpEF, not to mention the improvement in kidney outcomes, but the overall magnitude is a little bit lower than in patients with reduced ejection fraction. The second set of therapies that have demonstrated really meaningful patient-centered improvement is GLP-1 receptor agonists, specifically semaglutide and tirzepatide, which both have been shown to not only lead to weight loss, but also to improve quality of life in patients with HFpEF. What I'm showing here is the results from the STEP-HFpEF trial of semaglutide in patients with heart failure with ejection fractions of over 45% and with BMIs of over 30. It's important to note the median BMI was 37. I think that 75% of patients had a BMI of between 33 and 40. So all individuals that kind of meet the obesity classification that we see in our clinic every day. And what you see is that the GLP-1s not only led to an 11% reduction in body weight, but also an improvement in the patient-reported health status as measured by the Kansas City Cardiomyopathy Questionnaire, the KCQ. They found a KCQ difference of 8 points, and I will just say that's a large improvement in average quality of life from a drug. Most drugs in the HFrEF space lead to an improvement of 1 to 2 points. So I think that this is quite meaningful. I think there's some question, is it just the weight loss or is there some sort of non-weight loss related effect? I think that the jury's out on that. For my practice, at least, I'm not sure it particularly matters because it leads to patients feeling better. The final class of therapies I'll mention is finerenone, which is a non-steroidal mineralocorticoid antagonist. So it's an MRA, just like spironolactone or eplerenone. There are some potentially important differences. First, it has higher potency and antagonism for the specific receptor that we care about targeting, the mineralocorticoid receptor. It's theoretically less likely to cause hyperkalemia. It's clearly less likely to cause sexual side effects like gynecomastia than spironolactone, although the difference there with eplerenone is a little bit unclear. There have been two large randomized clinical trials that tested finerenone compared to placebo in patients with diabetic kidney disease and concurrent microalbuminuria. And in both of those trials were shown to prevent kidney disease progression. And when you pull those trials together, also showed a reduction in cardiovascular events. The Fine Arts trial was published just a year and a half ago or so. And in this trial, they actually took finerenone and evaluated it in patients with heart failure with ejection fractions of over 40%. They randomized patients to finerenone or placebo. And they found patients that received finerenone had about a 16% lower rate of the primary composite outcome of cardiac death or heart failure events. It's important to note the difference was mostly driven by the difference in heart failure events, which was about 18% lower with finerenone. The difference in cardiac deaths was not significant. There was also a small benefit in patient-reported health status. I will say that this trial comes on the background of us wondering about the benefit of MRAs for heart failure with preserved ejection fraction for quite a while. There's a trial that many of you likely know about 10 years ago called the TopCat trial that compared spironolactone and placebo. The trial is an incredibly interesting story in itself. It was conducted in US, Canada, Argentina, Brazil, Russia, and Georgia. And the trial failed to meet its primary outcome of the composite of cardiovascular death or heart failure hospitalizations. It did lead to a significant reduction in hospitalizations of 17%. But what's really interesting is when they broke out the trial by region, they found that patients in the Americas had a significant benefit. Those in Russia and Georgia did not. What was quite odd is that the patients in Russia and Georgia looked nothing like the patients in the US with much lower event rates. On top of that, when they checked the urine of patients randomized to spironolactone in the Americas, they had evidence of spironolactone metabolites. When they checked the urine for patients in Russia and Georgia, there was no evidence of any spironolactone metabolites. So this has led to the widespread concern, or maybe even to go so far as belief, of misconduct in the Russia and Georgia sites. And it's made a lot of us believe that spironolactone probably works to improve outcomes in HFpEF despite the negative trial. So to summarize kind of my thoughts on the treatment of HFpEF, I want to first make sure someone actually has HFpEF beyond the chart, either based on symptoms and risk factors or based on prior clear objective evidence of volume overload related to their heart, such as hospitalizations. For everybody, I try to start them on an SGLT2 inhibitor as long as they don't have contraindications and they're able to afford. We use a lot of cost plus drugs and a lot of patient assistance programs. I also have a low threshold for using an MRA or a non-steroidal MRA. Before the Fine Arts trial, I used MRAs quite routinely. I think the Fine Arts trial also increases the likelihood that spironolactone and the eplerenone are helpful in this case. So I give MRAs to anybody that needs diuretics, anybody that needs potassium, or anyone that still has symptoms after you start an SGLT2 inhibitor. So I use them quite widely. It's really important to remember to check potassium before starting an MRA and to check it after you start an MRA within 1 week, because obviously these drugs do increase the risk of hyperkalemia. For anyone with an elevated BMI with clear HFpEF and symptoms, I will recommend weight loss, and I increasingly do use GLP-1s for this indication as well. Obviously, I don't have to tell you guys that coverage is quite challenging, and so that's something that we battled through. On the other hand, one nice thing about it is one of the few therapies that patients are excited to start because they're excited about an option for effective weight loss. And then I think one thing I'll also mention is I'll often stop patients' beta blockers. It's important to note beta blockers are often initiated because these individuals have heart failure, but beta blockers have never been shown to improve our outcomes in patients with heart failure preserved ejection fraction. And often patients will feel better once the beta blockers are stopped, especially if they have a small heart cavity and they have a low heart rate with the beta blocker, and coming off of it allows their heart rate to rise. It's worth noting that there's exceptions to that when the beta blocker is being used to control their atrial fibrillation rate, for treating their angina that they have because of their coronary disease, or if they actually have improved ejection fraction, which I'll get to. I use diuretics pretty aggressively to minimize edema, but as I mentioned at the start, I really try to first start with SGLT2 inhibitors and MRAs, and then use the minimum diuretic dose as necessary. it's really important to really emphasize that diuretic dose changes over time. The diuretic dose that someone gets discharged in the hospital will almost certainly not be the right diuretic dose for them long term. So don't be afraid to adjust that up or down and monitor effects in terms of if they feel better, or if they have signs of side effects. Often, if someone has shortness of breath and has some amount of edema, but they tell me that that edema is long-standing and they don't think it's related to their heart, I'll often still try them on a higher dose of diuretics and just let them know to tell me if they either feel better or if they feel dizzy and their creatinine rises to try to decide. And similarly, when patients feel relatively good, but their blood pressure is on the low side, I'll often try coming down on their diuretic and just tell them to let me know if their weight goes up and their edema worsens. Blood pressure control is quite important, mostly for preventing progression of HFpEF, and this is a place where ACE and ARBs are really great. And there may also be an independent treatment benefit from ACEs and ARBs, independent of blood pressure control, and then encouraging exercise and strength training as possible. My last couple slides, um, it's important to mention mimics of HFpEF, which cause heart failure, have preserved ejection fractions, but need potentially separate treatments and need cardiology evaluation. So if you see patients with moderate or severe wall thickening that either don't have end-stage kidney disease, have not had long-standing decades of uncontrolled hypertension, you should think about a cardiology referral for evaluating for amyloid or hypertrophic cardiomyopathy, especially, hypertrophic cardiomyopathy when it's young patients, patients with family histories of sudden death. In patients that have a lot of arrhythmias, heart block, ventricular tachycardias, think about sarcoid. I believe that most patients with heart failure should have an iron panel checked once just to screen for hemochromatosis. And then in patients with prior radiation, prior surgery, thinking about pericardial disease, which is often missed. And especially in patients with a really bad right-sided heart failure, a lot of edema, more so than shortness of breath. In terms of heart failure with mildly reduced ejection fraction, it really does fall somewhere in between how we think about HFpEF and HFrEF. Some of the therapies for both groups have included this EF range in the clinical trials. I generally treat it closer to HFrEF using the same therapies, and really emphasizing that the risk is greater than those with ejection fractions of over 50%. That this in-between group is a group where there is some data for benefit of beta blockers. But I also acknowledge that there's probably less benefit with therapies and more uncertainty than those with lower EF. So while I try to use quadruple therapy, as you guys have talked about before, I have a lower threshold to stop if the patients have asymptomatic hypotension or side effects, a lower threshold to not initiate if costs are challenging for patients. It's really important to track ventricular function in these patients to see if it's worsening, because it often is kind of a halfway point to reduced ejection fraction. And then finally, in individuals with improved ejection fraction that was initially below 40% and then improves to above 40%, we categorize these patients separately, and think of them differently than patients with HFpEF. And this is often challenging because of kind of the fragmentation of medical records where we don't necessarily know what their EF was previously. These individuals, even when their EF goes back to over 50% and their symptoms are gone, are still at significant risk of heart failure and worsening. We often think of this kind of using the cancer paradigm as kind of heart failure in remission. And we believe their risk of their EF worsening is elevated if we stop their therapies. On the flip side, their risk is lower than when their EF was less than 40. So I don't uptitrate therapies with the exception of starting SGLT2 inhibitors if patients want to be really aggressive, or uptitrating therapies to control blood pressure. I do try to get them to stay on therapies to reduce their risk of worsening, including the beta blocker, and try to routinely check an echo every couple of years, 1 to 2 years, or if they have symptoms. So just to summarize, there's a lot we can do to help our patients with HFpEF feel better and stay out of the hospital. Would really prioritize SGLT2 inhibitors and the MRAs or non-steroidal MRAs over diuretics, using diuretics as needed, not being afraid to change the dose. GLP-1s can really improve symptoms in patients with heart failure and obesity, and then look for mimics that need cardiology evaluation. Thank you for giving me the time to share these thoughts.
Thanks, Alex. That was great. Wonderful overview of HFpEF, which is complicated. And I think we have a great case today that we'll get to in a bit that illustrates some of these points. So for everyone in the audience, please feel free to raise your hand, or put questions in the chat, and I will go ahead and start things off. So, Alex, is there any utility in kind of phenotyping someone with HFpEF? There was talk of this, Sanjeev Shah and others at Northwestern. Are there differences in kind of tailoring treatment to someone who has kind of an obesity phenotype versus kind of like the little old lady with a small ventricle and that sort of thing, chronic kidney disease? What are your thoughts on that?
Yeah, it's a really good point, Chris. I think there's a couple points to it. I think the one definite yes that Sanjeev Shah often talks about in his talks is not missing the mimics, where there's a different, there's a specific disease process that's driving the disease that we really want to identify. The focus on those mimics has really evolved as therapies for them have evolved. So now that we have a lot of therapies for cardiac amyloid, there's an increasing focus on recognizing amyloid to start amyloid specific therapies. Other than mimics, you're totally right that HFpEF still does have a range of kind of pathophysiologies and manifestations. And I think to some extent, trying to understand what the risk factors are for risk factor control is really important. To some extent, we're a bit limited um, in kind of our understanding of treatment benefits that we still enroll the majority of individuals in a trial. And so we don't necessarily know whether what is the specific phenotype that benefits from one specific population. I do think that recognizing that those kind of differences in the modest treatment benefits, I think it's more reasonable to really think about intolerances and whether therapy is right for a certain patient. The example of that there are some patients with really small ventricles where for some reason they actually don't tolerate any SGLT2s or MRAs because of the modest diuretic effect. And
Mm,
they end up describing a really substantial dizziness. And despite the fact that they have heart failure by all definitions, they might actually just have too high of side effects and that actually stopping the SGLT2 inhibitor feels better. So I think it's a
mm,
little bit more iterative on the patient's feedback of their response to treatment.
yeah, as opposed to HFrEF, which is a little more, you're like going for the same thing with most people. Interesting. So we have a question in the chat. With the general population using more GLP-1s, this is from Sarah Rogers. Have you seen more patients going into remission?
The remission concept for HFrEF, not necessarily. I mean, I think we're increasingly using GLP-1s in patients with reduced ejection fraction, but I think with still some uncertainty about the kind of safety and potential side effects because they haven't been studied in large trials. And we have not necessarily seen signals that like in the reduced ejection fraction population that GLP-1s lead to improvements in ejection fraction. That definitely has not been demonstrated. In the HFpEF population, we're using them with, strong reassurance about safety and kind of increasing use. And I will say there's definitely a number of patients where clearly the obesity is a major driver of their HFpEF and their symptoms, and they feel dramatically better. I had one patient that was admitted over 20 times in 2 years, and we've tried everything with diuretics, et cetera. And with 40 pounds of weight loss on a GLP-1, he stayed out of the hospital for 6 months, and this is for the first time in several years. So I think that we are definitely seeing, and this again speaks to like what is the phenotypic driver. I think in patients with HFpEF where obesity is a clear major driver, I think GLP-1s can have major effects.
Great. Maybe while others are gathering questions, if I could follow up on that and say, have you ever told someone they don't have heart failure anymore, someone with HFpEF who, for whatever reason, just, they lost a lot of weight, their diet and exercise changes, and they really don't have any symptoms of heart failure anymore. And they have a normal ejection fraction, normal diastolic function. What would you tell that person?
Yeah, it's come up both with actually individuals that had obesity without other signs of diastolic dysfunction, as well as with individuals that potentially had volume overload related to like high doses of steroids for like Dress syndrome or things like that, where they had congestion in that context. We treated them with not only decongestion, but with SGLT2 inhibitors and MRAs. And kind of after they've come off the steroids, after they've lost weight, they haven't really needed diuretics. Their echo diastolic function looks normal. And we kind of tell them that, you know, you don't really, I mean, exactly what you said, you probably don't have heart failure. I mean, there might be still something about your heart why, not everybody with high dose steroids gets fluid congestion. So there's something about your heart and kidney combination. Um, but at this point, I think your risk is much lower. And then I think really shared decision making. And I think some people are like, I feel so good, don't touch my meds. Other people are like, yes, if I can come off of them, would
Mhm.
happily come off of them. And I think the key is once they come off of them, make sure that they both symptomatically and from a volume standpoint continue to look good.
Well, I think we'll go just a couple more minutes, then transition to the case. And I have a question maybe some people in the audience are wondering. You talked about atrial fibrillation. Can you talk about rhythm versus rate control strategies? This is something that has evolved over time in patients with heart failure, particularly heart failure with reduced ejection fraction. But for heart failure and preserved ejection fraction, how do you think of rhythm versus rate control in your patients with atrial fibrillation?
I think the answer is easier in patients with reduced ejection fraction, definitely. Although I think it's maybe a similar answer as I think it through. I think we have an increasing amount of, you know, data about the benefits of rhythm control, especially early on in someone's disease course for kind of changing the life course of atrial fibrillation and the long-term structural remodeling. A large number of our patients with reduced ejection fraction, they symptomatically feel worse than atrial fibrillation. So we're pretty aggressive about rhythm control. Now have kind of 3 to 4 small clinical trials that all suggest hard cardiovascular benefit. In the HFpEF population, we don't necessarily have those, clinical trials that clearly demonstrate long-term clinical benefit. So I do leave it largely up to the symptomatology and the preferences of the patient, how aggressive to be about rhythm control. In the vast majority of individuals, I strongly suggest they let us try once to get them out of it, just to make sure they know if they feel better or different. And in many cases, they do. They're cardioverted and they say, I feel a lot better. And then we try to aggressively pursue rhythm control. In some cases, they don't. And in that case, if they say, I don't want more cardioversions, I definitely don't want an ablation, I think it's quite reasonable to pursue rhythm control as a rate control. But in the vast majority of individuals, I will suggest that they at least once try cardioversion to try to see how their symptoms differ when they're in rhythm versus rate. And I think the symptoms really drive it for HFpEF, given the lack of kind of long-term outcome benefit data.
Yeah, great. Well, I could ask you questions forever, Alex, but that's not the purpose of this session. So, one last chance. And if there are none, we'll maybe transition to the case. Is that okay, Lindsay?
Sounds great. We'll just give a little pause.
I have a quick question.
Go
So,
ahead.
we've kind of talked about this before in terms of, echocardiograms and um, not commenting on diastolic function. Can you talk about like what we should be looking at on echocardiograms to look at diastolic dysfunction in patients when it's not obviously notated?
It's tough. And I think it's tough from the perspective of a cardiologist, both because of variability in reporting and variability in the significance of those findings. But I'll give a few things that I look at for every echo report. One is the RVSP, or the PA systolic pressure that's estimated. These measurements are frequently underestimated, not because of operator error, but because of just the difficulty in correctly capturing it. But in the vast majority of our patients, the right ventricular systolic pressure, the PA systolic pressure, is a representative of what their wedge pressure, their left-sided pressures are in the vast majority of individuals. So when that's elevated above 35 and the patient has shortness of breath, it's quite likely that something going on in their heart and lungs is the cause of their shortness of breath. And it's very likely that that's actually heart failure. The reason I say very likely but not definite is it can also be elevated due to pulmonary hypertension itself, which can be due to problems in the lungs itself and obviously not problems in the heart. But I do look at the RVSP quite closely, acknowledging that it's often missed. Sanjeev Shah, to say his name again, will often say the left atrium is the ejection fraction of HFpEF. And in individuals that have chronically elevated pressures in their heart, which is what HFpEF is, the left atrium is often dilated. So left atrial dilation with concurrent, pulmonary symptoms of shortness of breath to me make the likelihood of HFpEF very high. There are caveats to that. In patients with longstanding atrial fibrillation, the left atrium can dilate by itself. Although, that being said, the comorbidity of HFpEF and atrial fibrillation is also astronomically high. But I think those are the two most obvious. And then there are other echo parameters that estimate left atrial pressure, which is what we're getting at. The one that you saw in the HFpEF score that I showed is the E to E prime. And the E to E prime ratio being, above 9 was the cutoff they used. There's probably more granular cutoffs can suggest the pressure being elevated. In some patients with HFpEF, part of the challenge is that actually all of their hemodynamic parameters look totally normal at rest. And it's only when they exert themselves that they have an abnormal response to that increased cardiac output and increased pressure. The gold standard of diagnosis is exercise-based right heart caths. We almost never do that at Stanford. It's challenging to do. The interventionalists don't like it. It takes up a lot of time. So that's where that kind of risk score comes in and kind of empiric treatment. I will say those individuals with exercise-induced HFpEF, I also believe they're less likely to benefit from the traditional therapies we talked about. They're the individuals where the comorbidity management is probably the best thing for improving their quality of life.